Hello, everyone, and welcome to this Facebook live stream. I'm Dr. Laura Buggers, and I'm the Chief Scientific Officer at Citizens United for Research in Epilepsy, or CURE. I hope you're all healthy and safe during these times that are challenging because of our real concerns about the novel coronavirus, COVID-19, and its implications for those with epilepsy. As an organization focused on funding and promoting epilepsy research, we are honored to host this event as a way to arm you, our community impacted by epilepsy, with the knowledge you need to make informed decisions regarding your care or that of a loved one. We are pleased to have a number of experts joining us today to answer your questions. Dr. Doug Nordley is a pediatric neurologist from the University of Chicago. And from the University of Illinois at Chicago, we have Drs. Jeffrey Loeb, who is an adult epileptologist, and Dr. Michael Carithers, who is a neuroimmunologist. Dr. Carithers is joining us by phone. If you have questions for our experts, please ask them in the comments section of this Facebook post, and my colleagues from CURE, Tasia and Brandon, will read them to our experts. We hope to make this session as interactive and informative as possible, but we ask that you keep your questions general and not reveal personal health information. If at all possible, I know we are already receiving questions, so let's get to that Q&A.
Okay, I think a great question, or a lot of questions have come in about who's exactly at risk. So I think we'll start there. And I'll kind of open this question up to all three of you and ask about the susceptibility to COVID-19. Are those with epilepsy more susceptible to COVID-19 from an adult or from a pediatric standpoint?
Who should start in?
Jeff, please.
Okay, so I think we're all susceptible. I think the susceptibility is equal. It's just how dangerous or how significant the illness is depends on our underlying comorbidities. In other words, do we have pulmonary problems? Do we have chronic medical problems? Do we have immunosuppression from another disease? From what I have heard so far, the course of children tends to be milder than the course of adults, which is wonderful news. But those who are elderly, who are disabled, who have underlying medical illnesses, who may live in, say, nursing homes with sort of more crowded environments are not only at higher risks, but also higher risk for significant morbidity. Michael, any thoughts about that?
Yeah, I would agree. Those patients who are over 60 years old are thought to have a more severe disease course and are increased risk of mortality. While those who are younger tend to have a less severe disease course, but on the other hand, they tend to shed larger amounts of the virus.
Interesting piece.
Yeah. Just to add to that and underscore, we're on regular communication, as you might imagine, with the infectious disease experts at the university, and they are reporting the same things, that we believe that children are at lower risk for manifesting severe symptoms, much lower risk. But one of the dangers is that they can carry the disease and spread it to others.
On a more related note, are there any, is there any knowledge or research right now about different seizure types and their susceptibility to COVID-19?
I'm not aware of any. I mean, it's just probably more of a general practice of what's important when you have a systemic viral infection. You are at a greater risk for breaking through with seizures. That's why it's so important to maintain compliance, don't run out of medication. Given the lack of interaction socially that we have, it's very important that folks do go and make sure that they have enough medication to get them through a time where they can't travel to get their medicines. So I don't know that one seizure type is more likely to break down than another, but clearly we know medication withdrawal is probably one of the major risks, which is more of a social risk than necessarily a sort of scientific or neurological risk for having more seizures. I'm not aware, Doug, are you of any subtypes of seizures that might be more likely to break through with viral infections in your experience?
Um, I would say, we don't have any direct experience with COVID-19, but if you were to take lessons that we know from other children with epilepsy, is that there are some subgroups of children who tend to be more susceptible to fever-induced seizures. For example, that would be our patients with Dravet syndrome, who seem to have a lower threshold when they get febrile illness. So not specific to COVID-19, but across the board. And if you canvass it or you run through in your mind, like who are the children who tend to have febrile or fever-induced seizures, tends to be our younger children, with under age 6. So, but that being said, I don't know of any data that would say that it's specific to COVID-19. It would just be associated with febrile illnesses.
And actually, one of the questions that we got earlier today actually dealt with a similar question. And will getting the coronavirus actually lower the seizure threshold? And if so, should seizure medications be increased at that point?
I would say no. I wouldn't empirically go ahead and increase the medications. And we need to be mindful that so far the disease manifestation in children seems to be milder. So thank goodness for that. So I wouldn't empirically increase medications, particularly because sometimes our medications could be sedating. And so, particularly the short acting ones, and we don't want to compromise someone's respiratory status by causing undue sedation. So definitely be in touch with your physician about this, and definitely not empirically just increase medications.
I agree because, again, when you have a systemic viral illness, you do have sometimes confusion, sleepiness, lethargy, and you don't want to confuse that because you increase the medications and cause those similar symptoms. So then you don't know what's from the virus and what's from the change in medication. So if patients are doing well on a certain medication, now if they start breaking through with seizures while they're infected, then of course we have to adjust the medication. But at that point, it should be under the care of a physician or in the hospital, not by individuals or family members deciding to do this on their own.
Yeah, great advice, great advice. Also, Dr. Carruthers, a question for you. Could COVID-19 actually trigger a seizure, even if you've been seizure-free for maybe a few years?
I really don't know the answer to that one. I mean, there's currently not a lot of information on whether or not this viral strain causes meningitis and encephalitis. There are a few limited case studies. Obviously, if there's an infection of the central nervous system, that would trigger a seizure, particularly in those individuals who are more susceptible.
Great.
Dr. Loeb, may have more insight into.
Yeah, Dr. Loeb or Dr. Nordlich, do you have any more insight into that?
I think we're at the beginning of our learning curve. I mean, we're in our hospital, we're very active. We have some suspected cases, and we're seeing neurological symptoms. Now, it's sometimes hard when somebody's very sick to say that it's directly from the virus or it's due to just being very sick. So I think as cases present to us, as I mentioned, it needs to be a very efficient and steep learning curve. So we know what to expect and we know what to anticipate is due to the underlying seizure or other disorder and what's caused directly by the virus that we need to worry about. And so we need to communicate well. We need to get information out as cases and information become available so that we can spread this knowledge widely and take the best care of our patients who have COVID-19.
Great. Kind of a similar question, dealing with epilepsy patients at a higher risk of SUDEP with exposure to COVID-19. Dr. Carruthers, could you maybe comment on that?
Yes, there's some theoretical evidence that the viral infection could increase the risk of SUDEP. This could potentially be due to a mechanism of the types of brain cells that the virus infects. It can potentially infect neurons that are in parts of the brain that control cardiac and respiratory function. This is because the the molecule that the virus binds to is present on those neurons.
Interesting. Any other thoughts on that, Dr. Loeb or Dr. Nordley?
As I say, I think, we need to watch very, very vigilantly and very closely with our patients. And if we start seeing more SUDEP, then we really have to become aware that that may be a sign that somebody has an infection or not, and diagnose it quickly and make sure we stay on top of things. I'm not sure we have a treatment at this point.
Right.
Other than supportive measures and very close observation if somebody is suspicious. But knowing that if there is a case of SUDEP with this virus, it's important that we know this and we make people aware of this. Not to scare anybody at this point, though, because we really don't know.
And I think with children, given that the disease manifestation is much milder, I think what we can do in this circumstance is, by virtue of being in close connection with our adult colleagues, is learn from what's happening with adults and then cautiously extrapolate that to children. But the good thing is that the manifestations seem milder.
Great. I'm going to actually combine a few questions that we received that were pretty similar, because I know that many hospitals right now are advising against patients, flocking into the ERs and into their physicians' offices. So how can patients be proactive, especially those that may have pre-existing lung disease or asthma or some form of respiratory illness? I'll open that up to all.
Well, I mean, it seems if you have a risk of serious consequences for a severe viral infection, you have to go the extra mile to make sure you're not exposed if you can. So clearly the social isolation is probably the most important thing that we can do now. Face masks may or may not help in this situation, but if somebody is suspected of having an upper respiratory infection, because the symptoms can be very, very mild at first, that person can be a carrier and could spread. So if you have a significant underlying medical illness, so that if you were to get the infection, you would have a tougher time battling it, you should take those extra steps to remain isolated and not be exposed to anybody, even if they have a little sniffle. Just keep clear of those people for now. Even if it's a dear family member, put a mask on them when you're around them, on the person who's sniffling and coughing, more importantly than on yourself, but maybe even on both.
Good advice. One of the questions that actually just came in recently is talks about anti-epileptic drugs and some research showing that these modulate immune activity. Are any of them known to lower immunity?
Well, some of the older agents, such as dilantin and carbamazepine, have been known to lead to bone marrow suppression, but usually your neurologist will be assessing that through regular laboratories. I mean, the virus also seems to suppress bone marrow production of both red blood cells and white blood cells. So it is a very important issue, but as I said, it should be part of your regular clinical monitoring.
And within pediatrics, whoever asked that question may be aware that with many of the new drugs that are studied, there's a very, very careful surveillance of symptoms within children, and we'll often see a slight uptick in respiratory infections, that are reported, but that's not suggesting some profound kind of immunosuppression. It's just a signal that's there. In clinical practice, I don't find that to be a very striking increase. So maybe if someone's seen that in a label insert, I think to put it in perspective, it tends, at least in my experience, to be a very mild. And I wouldn't, given all, you'd have to weigh all these things, but I would say in general, I wouldn't be tempted to alter your anti-epileptic medications for that theoretical consideration.
Since I heard about this question, I did a little research and didn't find much. There have been a few studies doing types of statistical or epidemiological analyses where they see, as Dr. Nordley said, a slight uptick but it's like 1 in 20 at best, and it's not really consistent. And you have to realize that a lot of folks who have epilepsy have other comorbidities and illnesses and developmental abnormalities. So if you just take a straight statistical measure, so I wouldn't be super concerned about it. I think it's more important, as I mentioned, to stay on your medications and don't worry that your medicines are causing immunosuppression. Take them because you don't want to have seizures.
Can I just jump in and ask if that's true also for treatments like ACTH, Afinitor, or everolimus, or which people with specific types of epilepsy may go on?
Doug probably is best to answer this question.
Yeah, I think, there are some times when we do put our patients on hormonal treatments and corticosteroids, aside from ACTH, it's stimulating the adrenal axis. So I would say yes, that there's going to be definitely one of the concerns that we have whenever someone's on ACTH is that we want to increase those precautions. So I always tell people children, infants who are going on ACTH or steroids, be extra careful, good hand washing. It's not a good time to have anyone who has any kind of respiratory symptoms to come over and visit at that point. They could save that for after the treatment's finished. So I would say, yes, that group should be even more cautious about exercising good hygiene measures and social distancing.
Thank you.
Great answers. There's been a lot of discussion about the known issues with ibuprofen and anti-inflammatory effects on the virus. Do we know anything, or is there any evidence that would suggest about the use of CBD being a concern if infected with the COVID-19 virus?
Not that I'm aware of.
I no idea.
No. One of those things
the everolimus, I think, that was mentioned before, is probably worth a comment because that is one of the major side effects of that medication is getting more infections. So if it's being used on label, off label for seizures, I think that is something that would definitely lower the immune response. Is that right, Michael?
Yes, that's correct. Or even in our patients with multiple sclerosis, we're on immune modulating medications that can suppress the immune system. Our current recommendation is for them to continue on therapy.
But not get exposed to the virus, hopefully.
Right. Here's a question actually that just popped up that might be more appropriate for Dr. Carithers, if we know anything about this. Would there be a higher probability for someone to get COVID-19 if their epilepsy was initially triggered by a viral infection?
Only if they're immune suppressed.
Okay. And for those patients who are immune suppressed for many different reasons, kind of what is their course of action? What should be their first steps to be more proactive in ensuring that they don't, contract the COVID-19 virus?
Well, the issue puts many people in a difficult situation. I mean, the recommendation is that patients who are immune suppressed practice social isolation and stay at home as much as possible. But this isn't always practical if you have a job where you can't take leave or something like that.
Absolutely. We are getting a lot of questions coming in about medications and I know that and prescriptions and refills, and I know there's still a lot that we have to know about that. But when taking epilepsy medications, if you're unable to take a lot of over-the-counter medications, because this might conflict with different ingredients, what are patients supposed to do in this case? What over-the-counter medications can individuals take to kind of mitigate the symptoms?
The current recommendation would be Tylenol for fever and general flu-like symptoms.
Dr. Loeb, Dr. Nordley, any?
I think certainly in small moderations, okay, but you don't want to overdo some of these over-the-counter medications because they could have pro-epileptic effects, such as the stimulants that we use to clear your sinuses, decongestants. You have to be careful not to overuse. When you're not feeling good and you just want to take something and you want to take more and more, you know, don't overuse it. And if you could get by just with the Tylenol or acetaminophen, that's the best strategy to avoid. Probably no side effects. Certainly reducing the fever is probably helpful to prevent you from having seizures. So at a minimum, that. In terms of ibuprofen, I don't see, maybe in children, but certainly in adults, I don't see any contraindications. Sometimes it lasts longer and has a bigger effect in terms of some of the myalgias and the other symptoms that you get than the acetaminophen.
Well, there were concerns from some French investigators that ibuprofen and other NSAIDs could make the clinical course of COVID worse. However, that hasn't been substantiated in a well-done clinical study.
And since we're talking about medications, I think this might be a great time to address just generally in your experience already, how is this COVID-19 virus, how is this affecting medication availability currently?
I'm not aware of any shortages other than the tests to get the virus detected. I'm not aware of any shortages of medications, regular medications. But I mean, it certainly could happen. A lot of people are working from home, who's doing deliveries right now. You know, it's the social isolation is going to have its downstream effects.
Yeah, likewise, we haven't been aware of any limitations for drug availability.
And has there been any discussions about, I know we've actually received a lot of questions that deal with drug availability in China. And if so, do we foresee a shortage in drugs that might be coming and distributed from that country in particular?
I'm not aware of any. I mean, it's clearly, you know, the manufacturing of drugs has become very international, and I wouldn't be surprised if there would be shortages based on plants being shut down. We don't really know when you get a pill where that pill was actually made.
There was actually, going back to kind of the discussions we had earlier about ibuprofen, we've actually received a lot of questions from mothers asking about giving their children Tylenol or Motrin. Dr. Nordley, what are your thoughts on that?
Yeah, aside from the information that was just shared with us, that's generally our recommendations, you know, that acetaminophen, ibuprofen can work very well. Sometimes with, as you know, with children, that in other illnesses like the flu, they can have very high fevers. So sometimes we'll alternate those two to keep the fever down. As Dr. Loeb was saying, that you know, that can be a threshold itself. Since children are generally manifesting mild symptoms with COVID, maybe the thing that's more likely to cause intense symptoms right now might be flu B. So I wouldn't jump to assumption that it's COVID-19, and it might be good to practice like typical kinds of approaches that we normally do to infectious illnesses, particularly since kids seem to be less affected. With regard to the medication, I had another thought, which is that don't want people to worry, even if there was some stress point in a system somewhere. As Dr. Loeb was saying, there's many other places that are producing drugs, and we have many alternatives. So lots of drugs work by similar mechanisms of action. So please reach out to us if there is any concern. But as I said, we haven't seen that at this point.
Yeah, that's a great point. Another question that's coming in, obviously surrounding children and their susceptibility. Is there any evidence or thought, Dr. Nordley, that children might be more prone to have seizures as a sign of the virus?
No, no, not as far as I know, and you know, monitoring the situation and hearing the experience from our colleagues in Italy that did not seem to be in children. So, and since it's milder manifestations, I'm hopeful that that remains the case. That in our hospital network, we are less concerned in the pediatric realm about acutely ill children and more about the effect that those children might have on their parents or healthcare providers. So hopefully that stays the same as it's been experienced worldwide. And really the brunt of the exposure seems to be, symptomatic manifestation seems to be adults, and then the more intense manifestations in people above 60.
Good point. And should parents be concerned specifically around those children that might have epilepsy and some sort of respiratory illness, about taking them outside for walks and things of that? We've received a lot of questions about, you know, how active they can be, especially being outside.
Yeah, I would say in general, maybe using, you know, parents using good judgment. You know, I was reading just earlier this morning the information from various sites about saying that going out, you know, particularly with a social distance, is fine. You know, we're not in a complete kind of shutdown situation, and I think for mental health of everyone, including children, to get outside is, you know, so long as they're separated from other individuals, has beneficial effects. Sometimes cold exposure can exacerbate respiratory symptoms. So that's where it would kind of be something to watch closely and see how the child reacts to being outside.
Great advice. I'm going to kind of end here with a few questions about kind of just general thoughts regarding epilepsy and the virus. Are there any thoughts that patients with epilepsy will have a more severe manifestation of COVID-19 than, you know, an individual without epilepsy?
I can comment on that. You know, when you have epilepsy and you have concurrent other illnesses, by definition, you have a tougher time. You have the risk of breaking through, having seizures, your medication's not working. If you have any change in, say, your function of your liver, that's not going to break the medicines down, or the absorption of the medications. So because you have epilepsy, because you have the risk for seizures, because you take this medicine, you are at higher risk just because of that. Because not only do you have the risk for the virus, but that this is going to, and we know in many viral cases, this is something we always ask our patients: have you had a recent infection or something? Why did you have this breakthrough seizure? So clearly we know that infectious illnesses lower our threshold to fight against seizures, and we have to be super vigilant. Be in touch with your physicians. Actually, physicians actually have a little more time. A lot of our regular clinics are canceled. So we can get on the phone and talk to you much more readily, probably less likely in person, if you have questions or problems. But yes, you want to keep taking your medications. You don't want to do anything that you know normally would make you be more likely to have seizures, sleep deprivation, stress, alcohol, all of those things that we know can lower your seizure threshold. If you add that together with your COVID-19, it's not going to be good.
Thank you. That's great advice. And then also, one of the other questions that we had come in specifically dealt with those patients that have brain surgery. So Dr. Loeb, maybe you can address this one. Would their ability to fight the COVID-19 virus be compromised because of a recent brain surgery?
I wouldn't think so.
Okay.
I mean, unless you were on some sort of medications, like steroids or something like that, like a very recent, you know, we talked about certain medications. So again, you know, talk to your doctors if something other situations are going on. Clearly, I think everybody has the risk. It's not the risk, it's the risk of what happens to you, either by breaking through a seizures or being immunosuppressed if you got the virus versus someone else. So yes, we have to be super vigilant for our patients with epilepsy, and especially for those who have those other illnesses like immunosuppressive treatments for at the same time.
Advice. And then are there any risks involved that you might foresee in allowing people that are potentially caregivers of children with epilepsy given into their home, given the warning to really decrease your social exposure?
I think on balance that I would say it's so much more important for the caregiver, the parent, to be attending to that child. If there's nice advice that's on the Illinois Public Health and the CDC about what do you do if you have symptoms and you've come down with infection, I would direct people to that. But say people are not infected and they're just caring, I think that everything being the same, comparing those things, I would have very little concerns as a parent. Say, nope, continue to care for your child as you would, just exercise the proper precautions. If you get sick, then definitely contact your doctor and figure out alternatives.
I think some of the stories I'm hearing is a lot of families are actually getting much closer together as a result of the social isolation. So we're being less social with strangers or people we don't know, but much closer with our families, which is actually kind of nice. But at the same time, if one of those family members does have cold-like symptoms, we do have to be aware that they could have contracted the virus and could spread it to that family.
Right. Great point. Yeah. And then to kind of wrap things up here, you mentioned this very briefly, Dr. Norley, about the CDC recommendations, but why does the CDC list epilepsy as a high-risk category for COVID-19?
I can't imagine other things other than what was already said about the potential impact of disease in adults on the epilepsy. I can't think of a physiologic reason. Maybe Dr. Carruthers could chime in here, why someone with epilepsy would be at greater risk for contracting the virus. I think it was more the points that Dr. Lurb was making earlier about the impact of the disease of COVID-19 on the epilepsy itself. Dr. Carruthers, anything else to add about that?
Yeah, I think they probably put epilepsy on the list because it's a chronic neurologic condition, and as we've spoken already, that there's no current evidence that epilepsy patients are at increased risk of infection. I believe the CDC is doing due diligence at this point in time because we have so little information available.
Great point. Well, I think that's pretty much all the questions that have come in, at least that haven't been addressed already through the live stream. Were there any last points that anybody had that they wanted to make before we kind of wrap things up here?
I have nothing else to add.
And just to say thank you to Cure for organizing this and providing this service for our patients. It's much appreciated.
Yes, very much so. And be safe, be careful, use common sense. Don't be shy about talking to your doctor, your nurses. Don't believe everything you read on the internet, and get close to your families. I think it's an opportunity.
Wonderful advice. Yes.
Thanks to you all. Thank you, Dr. Loeb, Nordley, and Carruthers. Be well, be safe, and we'll see you soon.
Yes, and I do want to add that this video will be available shortly, both on the Cure Facebook page and on the Cure website. Also, stay tuned for more updates from Cure as new information does become available. Thank you again all. Thank you to our panelists. Be healthy and stay safe.
You too.
Thank you.
Bye-bye.